Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hi everybody, I'm Joseph Gravino.
I'm Clay Case.
And we are the Millennial Mechanical Therapists. Today we're going to do a dual video on our personal stories of why we chose to go the route of McKenzie method or mechanical diagnosis and therapy, and what steered us to treat our patients in more of a mechanical nature. I'm going to go first and then Clay will lead up. Yeah, I am going to start.
Go for it.
All right. So getting into things. My story started in college. I think Clay's did as well. But in our doctorate, I was running for my first. I attempted to do a half marathon, and I was training for it and was never previously a runner. You'd think that some of my biomechanical knowledge would have helped with that, but it didn't. It truly didn't.
I'm sorry to hear that.
So, long story short, I ended up starting to get right-sided low back pain that went into my hip and down into my thigh. And I figured I went through my orthopedic year. I relatively knew what I was doing. I stretched, I strengthened, and
Should be good to go, right?
I even did tool-assisted soft tissue to my thigh and my IT band,
Good.
And just nothing changed.
All valid.
I thought so.
Yeah,
I thought so.
I agree.
And then at the time, one of our professors who was certified in mechanical diagnosis and therapy had some office hours, so I walked into his office and said to him what I'm saying to you. He started treating me with, more of an MDT or mechanically mindset. Now, I did try to play around a little bit with prone press-ups and then side glides, but nothing seemed to influence it at all. And he really showed me what a true mechanical assessment should have been like. And after about, I'd want to say 20 minutes, I centralized into my low back, and it took some repeated extensions in line with clinician overpressure to truly get my symptoms to come in. But that was nuts because I was dealing with this for a couple weeks. I thought I knew what I was doing, and that just blew my mind because I never really thought about adding more pressure than just the extension. After that, he took me through, within about 2 to 3 weeks, I was done. I went through the recovery function phase, if you're familiar with the protocol, and I was good, and I was able to run. Now, I never ended up running that half marathon, but that's a different story.
How's your back now?
My back is phenomenal. Still doing my prophylaxis exercises. Good. But really, the cool thing was I was able to learn from my own pain, my own mistakes, and then I followed that clinician around whenever he was treating patients on campus, spoke with him about the method as much as I could, and I just truly ended up, I guess, really just falling in love with the assessment, falling in love with the fact that I didn't need to rely on palpation skills that I had none of.
Those are scary when you're learning them.
Horrible. I was horrible, to say the least, and it gave me some clarity, I guess, as not even a practicing clinician. It gave me clarity on things to come, and really to start my career, I think it made me much, much more effective and more efficient being a new graduate. So that's my story. So now I'm going to pass it off to Clay.
Yeah, my love for this got way farther into our career because yours was that was our first year, right?
Yeah.
Of graduate school, if you will. That was really when we were learning physical therapy things, not just the stuff from the beginning, but. Mine really kicked in our last year.
Okay.
During that semester, the first semester of our last year, I sat for the Certified Strength and Conditioning Specialist exam.
I remember that.
Throughout my whole college career, I always have helped coach basketball. I just love doing it. So that's what I always thought I was going to do. I was that kid that every professor was like, PT's not just sports. You're not going to just go into sports. I was going to go into sports. I was going. So I sat for that, passed it, got it, and then I went to the sports metrics course that summer actually previously for ACL injury prevention. So I went through those two things, and I got out on our third clinical. Mine was in an outpatient orthopedic setting, and I kind of went in there. I was like, yeah, I know how to treat all of this sports-related stuff. But everything I learned from the book, from CSCS, from sports metrics, you got to take like 6 weeks. You need 6 weeks of training to hypertrophy muscles. You need at least 3 weeks for neuromuscular gains, things like that. And I was just like, man, there's got to be a quicker way. I'm American, so there's got to be
we like
a quicker
it fast,
way.
fast and cheap.
There's got to be a quicker way. So I learned MDT a lot, and when I talked to this guy a little bit and our professors, we had MDT through our curriculum a ton. I took A and B in school. You know, we're fortunate enough that our college offered that.
Yeah, they provided that for us.
Yeah, it was awesome. It was a cheaper rate, which was clutch being in college.
It's much nice when you can't even afford food.
Oh yeah. So on that internship, my CI was certified in MDT, and he used it kind of in conjunction with other stuff, which is cool. But I really took the reins and just went at it. I looked at the books, went at it, and the first patient that I suspected was like lumbar, dude, knocked it out of the park with MDT, and I couldn't look back. I love doing the sports stuff when it's really just training. I don't really like it for rehab. It doesn't click with me, and there are a lot of people that do it really well.
Yeah, no, there definitely are a lot of people out there that do it well.
But it just doesn't click with me. Kind of like I said before, palpation, man, you don't want me doing the palpatory exam.
No, not at all.
I just stick with the patient response in MDT, and it just gelled from there. Like I said, I haven't really looked back.
That must have been interesting, though, as a student to have kind of take the reins from a certified clinician who was kind of practicing in multiple different manners.
Yeah, he would bounce back and forth. He had a couple clinics that he would work at. So the cool part about that internship is all the patients. It was very group-oriented therapy in a way. I mean, you probably saw every therapist at one point. So as I was going through, I just kind of was like, these are some nice exercises. Let's do some MDT and see if we can flush this out real quick, because it's what I was comfortable with. The other stuff wasn't wrong, wasn't bad. I think most of the people were getting better, but if I could get them to buy into it, it was just so much easier, especially when they started getting educated with their exercise and they really saw that cause and effect.
Yeah.
So, like I said, it's tough to sell cause and effect when the effect comes 6 weeks later.
Yeah.
Jeez.
No.
I can't even say it.
Yeah, besides you not even wanting to spit it out. No, I think there's a lot of correlation with why a lot of people start MDT or end up going down the track of trying to become certified or diplomat. And this isn't talking to some people on the other courses and whatnot. Everyone has a similar type thought process that they were introduced to it. They wanted quicker results. They were heavily based in manual therapy, and they just weren't getting the results that they really wanted.
Right. Not that MDT doesn't have manual.
No, yeah. We'll talk about that. You'll hear that from us definitely more than once.
Oh, yeah.
But the manual therapy that comes with MDT is just a little bit more specific and a little bit more patient-centered than just general manual therapy. Right. And I think there's, unfortunately, in our specific profession, there's a lot of things out there. There's a lot of ways that you can treat, and there's a lot of things out there. And we'll never try and tell you this is the only way. Yeah. But this is what we found clarity through. And when you look at the research, if we try to be evidence-based clinicians, there's really no research to support probably 90% of the stuff that we do. And that's pretty scary when we're trying to fight for more reimbursement and more representation and
more privileges, things like that.
Exactly. Now, I'm not saying other professions have evidence-based practice, but if we're going to pride ourselves on that, then we really need to kind of put our money where our mouth is, so to speak, and really go up there. And unfortunately, it's not. And the beauty about MDT is it really doesn't take into consideration a lot of the things that have been shown to not really be effective clinically.
Yeah.
Which is nice and really takes the pathoanatomical world, kind of puts it on the back burner to allow you to assess the patient, see what you think they need, see how they respond to movement, and then see hopefully that those things match up.
Yeah.
But if they don't, if the patient's going to get better quicker, then I guess it's up to you and anyone else who's involved to figure out if that matters.
Yeah, it's really easy to sell that, and although the disc model is so, I want to say the word like, it's so synonymous with MDT now, but it's not. It shouldn't be. You know what I mean? It's kind of erroneously synonymous with that. So when you go through it, maybe that's a useful tool, and it makes sense on paper to patients a lot of times. It really does, and that can help you get that buy-in. But hey, sometimes it really doesn't work. Sometimes when you close down a side, it's painful. They get worse. You open up that side, and you're going, well, I'm blowing that disc out according to this model, but they feel better. So it's really cool how just going by that symptomatic response, going by your patient, can blow pathoanatomics kind of out of the water. And then as a new grad, that's one less thing you really have to think about. You don't have to justify what you're doing other than, do you feel better? And patients go, yeah. You're like, well, who cares then?
I agree. And before we get too deep into this, there's going to be a part 2 on more information on why we do this, a little bit more nitty-gritty on what Clay is alluding to right now. So stay tuned, stick around for the next one, and we'll see you guys soon. Remember, move your patients early.
You better move them often.
And move them to end range, because that's where the magic happens, my friends. See you next time.